Hi, I'm Andrea Watkinson, Executive Director of Cancer Services for Unity Point Health, St. Luke's Hospital, and the Nassif Community Cancer Center in Cedar Rapids, Iowa. As a leader in cancer screening and treatment in Iowa, we're proud to sponsor the Iowa Ideas In-Depth Week Cancer in Iowa series. As Iowa continues to see some of the highest cancer rates in the nation, it's more critical than ever to address the issues causing this trend and to educate our communities on the resources available in our state. This series will take an in-depth look at everything from cancer rates and causation to research and long-term impact cancer has on the state of Iowa. We'll also discuss advancements in treatment and how crucial it is to complete your cancer screenings regularly and on time. We hope you find these sessions informative and find valuable takeaways. Our overall goal at Unity Point Health, St. Luke's, and the Nassif Community Cancer Center is to reduce cancer rates and work towards a healthier state for all Iowans. Enjoy the event.
Hi, everyone. Welcome today to the Gazette's Iowa Ideas In-Depth Week. This is our 9th year doing this, and we do a big conference at the end of the year, but we do these in-depth weeks along the way, and this one obviously is on cancer in Iowa. We want to start by just thanking our presenting sponsor, ITC Midwest, and then this in-depth week sponsor, Unity Point Health, obviously, for supporting the event. It's the reason that we're able to do it to the public for free. So thanks so much. I'm Vanessa Miller. I'm a reporter with the Gazette. I've been covering higher ed and healthcare for years now. And so I'll be moderating this session with our 3 panelists, and just want to start off at the front, letting you know that we'll take questions throughout the session, kind of to keep that conversation going. So if something occurs to you that you want to share, put that in the group chat or in the Zoom chat, and those will be shared with me, and then I can throw them to our panelists as we go. So we'll get started. I wanted to start by just asking each of our 3 panelists to kind of introduce themselves and share a little bit about what they do and their connection to the topic. So maybe we can start with you, Dr. Cullen.
Sure. Joe Cullen. I'm professor of surgery at the University of Iowa College of Medicine. I've been a faculty member here for almost 32 years now. And our research and our lab is investigating treatments for pancreatic cancer. And we just published a very high impact paper looking at high dose vitamin C in the treatment of pancreatic cancer, and saw very positive results.
Awesome. Thank you. And then Dr. Correa. Oh, you're muted. So sorry.
I'm Candace, Correa. I'm a radiation oncologist, and I practice in Cedar Rapids, Unity Point. So I treat all different types of cancer, but my background is I've done a lot of breast cancer research. So that's kind of, and women's cancer treatments. So that's kind of a little bit specialization for me.
Great, thanks. And Cathy.
Hello, my name is Cathy Ketton, and I am a breast cancer thriver, 2 years now. And I'm also co-founder of a breast cancer support group called Splash of Color Breast Cancer Support Group. And I'm an advocate for women in Waterloo.
Perfect. Awesome. Well, thanks again so much for being here. And I wanted to start with a kind of a broad question about what like the landscape is, I guess, right now. We can start with maybe the screening piece of it. What does that look like for people? And I know it's going to vary by different populations and different cancer types, but have we made advancements compared to 10 years ago, or is this still an area that we need a lot of work in?
Maybe I can join in. I think the screening for diseases like colon cancer, breast cancer have been established, and I think they're shown quite nicely how they improve early detection of cancers. The newest one I think that's come on is detection of lung cancer, and that has shown some promise too, as far as detecting lung cancer in an early stage, specifically in smokers or people with high risk of developing lung cancer.
What does that look like for lung cancer? What does the screening actually look like for early?
Yeah, it's just as I understand, it's just a chest CT,
Okay.
which can be done pretty routinely in most centers, and so not very invasive, but can really delineate the cancer if there is one there, or if the patient is clear.
Right. And is it something that somebody does like at a certain age, like they do for like a colonoscopy, or is it like if you have a history of something?
Yeah, it would really be a history of smoking. As far as age, I think it's more pack year history of smoking, but I think the screening starts in ages between 40 and 50.
Got it. Okay. Yeah. And are you in terms of like screening for other cancers? I mean, are like I know the colonoscopy thing is at a certain age. I mean, are we trying to get something like that preventative in place for all the types, or are some of them still just symptomatic if you come in, you know?
Yeah, a lot of them it is symptomatic. Skin cancers are very common. Can be screened at in a primary care or a dermatologist, but something more deadly, I guess, like pancreatic cancer, it's patients develop symptoms, and no type of screening really has shown any impact in something like pancreatic cancer.
Sure. Yeah. I mean, I don't know if either of you doctors have numbers, but what is the impact of screening? I mean, how meaningful can that be to catch something early, for example?
I can speak to the breast cancer situation. So, since we've started screening routinely in this country since about the 1980s, there's been over 30% reduction in breast cancer mortality. We think a lot of that is due to screening. At the same time, we had advances in treatment like anti-HER2 new therapy, different types of anti-endocrine therapy, different types of stronger chemotherapy. So they contribute somewhat, but a big chunk of that is probably from the screening. So we have significantly reduced breast cancer mortality. Any country that institutes screening, you automatically reduce the breast cancer mortality, and it's a similar picture for a lot of other cancers. So when we say, why do we screen? We want to screen not to just catch a cancer. We want to catch a cancer that we can do something about and reduce the risk of a patient dying of it, not just to catch it early. That's why some things like the prostate cancer screening are a little bit controversial, because a lot of those cancers are not deadly. They don't have a risk to the patient's life. So the screening guidelines I kind of prefer. There's different sets. American Cancer Society, I think, has a good, if you go to ACS. I think it's .org. They will list all of the recommended screenings and the ages that you start them.
Mhm.
Just a caveat that this is for an average risk person. So obviously, if you have a family history of something like colorectal cancer or prostate cancer or something like that, you may not want to follow just the standard guidelines, because if you have a family history, you might have a hereditary component. So you may want to start screening sooner than that. But I think that the ACS does a good job of kind of outlining all the basic kind of cancer screenings that there are, and when to start. And just to give you an idea of the scope of how many people undergo cancer screenings. So colonoscopy and breast rates they're really good. The screening rates for those, they're 70+% over the past couple of years. The lung cancer screening rates are still abysmal. Okay, they are like less than 25% of eligible patients are being screened for lung cancer. It is partly because it's newer, so it may not be on as many doctors' radar. But actually, the lung cancer screening trial that kind of established it as something to do, because before we used to use chest x-rays. You can't see lung cancer very well on a chest x-ray unless it's very large. So again, you don't move the needle in curing more cancers. When we started using helical CT scans, you slice through the lung, so you can see small lung nodules. You can catch very small lung cancers. And so you can do something about them. Those are highly curative if they're like stage 1 or stage 2. So for the lung, the ACS is age 50 to 80 if you're smoking, or if you have more than a 20 pack year history within 15 years, they recommend an annual low-dose chest CT. So we really need in the community to get those rates up to catch those early lung cancers, to not only reduce the risk of dying of lung cancer, but there's some evidence that it may impact all-cause mortality. So risk of dying of anything if you catch the lung cancer early.
Right. Yeah. Yeah. And some of what you were just saying really reminds me, I mean, because what we're seeing in these cancer in Iowa reports, obviously, is that while the rates are going up for Iowa, the death rates are going down. And maybe part of that has to do with the early screening, right? That catching it early can make it more treatable or curable in some cases.
Definitely. So Iowa is number 2 in the nation for cases.
Mm-hmm.
It's dead center, number 24 in the nation for deaths. So that's actually really good news, in that a lot of the cancers that are happening are not deadly.
Yeah. Well, and I was wondering, I mean, we're talking about screening and catching things earlier. Is that at all tied to that rate increase? Just that we're like catching more of them, or do we really think there are more cancers happening and occurring?
I would say a lot of that is probably tied to the risk factors for cancer. So we have increasing obesity and overweight in this country. So in terms of risk of cancer deaths, smoking is still the number 1 cause of cancer deaths. But if you look at cancer cases, being overweight or being obese has been linked to more cancer cases than actually smoking. So there are 13 cancers associated with being overweight or obese. And when you get into especially like the ultra obese category, the risk goes up even more, so if you have something like twice the risk for overweight, 4 times the risk for obese, if you get into ultra obese, it's even higher than that. So it's a trend in sort of the population change in terms of the obesity rates. I think it's what is driving a lot of it. I think what everyone wants to know is something environmental. Is there something in the water? Is there something in the air? Is it the organophosphates? Is it the PFAS or PFAS? And I don't think we have a clear answer on that. It hasn't been well studied, to my understanding, what is all of the components that are driving this. But I would say that the obesity epidemic is definitely driving a lot of the cases.
Sure. I'm wondering how much like some of these screenings cost. Is it pretty expensive from like an insurance perspective or from a patient perspective? Like, do we still need to be pretty select in who we screen for certain things based on risk factors, instead of just doing these blanket screenings for everyone, just to be sure? Okay. Either of you.
I would say if someone is healthy, they should be screened. So sometimes we get for breast cancer where women are healthy and they're over 80 and they stop the screenings. But, really, if someone is still able to be treated, I would say continue the screenings. Just because you meet an arbitrary age cutoff, if someone is otherwise healthy, there's no reason not to screen people till they pass away or have so many medical comorbidities that we wouldn't be able to treat them if we found a cancer. So that's my take on it. I don't know. Some doctors might have a different take, but
sure. I agree. I agree completely with that. I mean, some 80-year-olds are more active and vibrant than a 60-year-old. So I agree totally with that statement.
Yeah. And Cathy, I know that you had, breast cancer in your family, from your daughters and yourself, obviously. I mean, what was the screening experience like for you? Did you guys know that going into it and, have any sort of extra checks or?
Well, when my mom was diagnosed, she didn't know anything about breast cancer screening, although she went to, her PCP appointments quite regularly, and I'm not sure why she didn't get screened earlier. She was diagnosed with breast cancer at the age of 58.
Oh, wow.
And so I don't remember her talking about any screenings. My daughter's, my 21-year-old, of course, she didn't know anything about screening when she was diagnosed with breast cancer.
Mm-hmm.
My 25-year-old, she knew a little bit about screening. After Nisha was diagnosed at 21, then that's when we all started, okay, we have to do our monthly self-breast, exams. And so we did that. And then after Nisha was diagnosed at 21, my 25-year-old was diagnosed the next year. So she had a year, to get information about, is this genetic breast cancer. She was doing her breast exam and she found her lump, and so did Nisha. They found their lumps themselves. And my 25-year-old was a nurse, so she knew a little bit about it. And then she researched it before she came and said, "Mom, I have breast cancer."
Wow.
And after that, of course, I knew that I had to check myself, and I got tested to see if I was the carrier, of their breast cancer, and I was not. And I got tested more than once.
Right. So everybody who was in your family, though, you all found your cancer through a self-exam first. Was that the first?
That is correct. Yeah.
Yeah.
We all found it. Mm-hmm.
Yeah. Well, and I wonder if the doctors there can talk about that, about sort of self-reporting, self-examining. I mean, how important is that as sort of a first line of screening for folks?
Well, I think in breast cancer, it's extremely important. The other thing similar to breast cancer, I would say also is types of skin cancer. If somebody has a mole that's changed or a lesion that doesn't heal on their skin, that's also a way of kind of self-examination that you can go see a primary care physician or someone else to make a diagnosis.
Yeah. Yeah. Because skin cancer is one you can do it for, obviously. Breast cancer. I actually had a thyroid tumor that I felt just as a lump and went in and had that checked out. So yeah, but some, like you say, are something that you need sort of an x-ray for, like lung cancer, for example. So I guess I'm wondering if you, any of you can talk about, both from the screening perspective and the treatment perspective, what some of the newer, you were talking about vitamin C, Dr. Cullen, but like, what are some of the new treatments, new screenings that we have right now?
New treatments. I think in the last 5 to 10 years, Dr. Correa can see this too, is the explosion, I guess I would say, of immunotherapy as a cancer chemotherapy, specifically in lung cancer, but it's also seen in it's also spread to other types of treatments for cancer. And I think in the last 5 to 10 years, that's been the biggest advance in cancer as far as treatment and chemotherapy.
And yeah, just for folks who don't know, I mean, what does that look like in terms of being treated that way versus like a chemotherapy, like a traditional type?
I don't treat patients like that, but I think as far as toxicity, there is toxicity associated with it, as there is with standard chemotherapy. Basically, instead of a drug fighting your tumor, it turns your immune system to fight your tumor. And there's been some just really remarkable successes. The most one that's I think is dramatic and people know about is the former President Jimmy Carter, who developed melanoma and metastatic brain melanoma. The melanoma metastasized to his brain. And he lived for quite a number of years with immunotherapy drugs. Yeah.
Yeah. And maybe talk a little bit about, you had talked about the vitamin C. Is that just specific to pancreatic that you're looking into? Or
No. So we've used it for a number of cancers, including glioblastoma, which is a primary brain cancer. And we showed about a year or so ago, it definitely improved overall survival. In pancreatic cancer, we showed in a randomized trial, which is more powerful, that it did double overall survival from 8 months to 16 months. And we also have trials in lung cancer combined with radiation therapy. And the results of that in initial phase 1 trials are excellent. And we're just completing a phase 2 trial at the University of Iowa. We just enrolled our last patient. So we can't wait to see what the results are on that. So yeah. we have used it. Other investigators have used it for multiple myeloma, kind of a blood cancer, with some initial encouraging results. But we keep on pushing it forward and seeing where we can go with it.
Yeah. And when did that first sort of pop onto the treatment radar? Like, when did that first start happening?
Well, it was promoted by Linus Pauling in the 70s.
Okay.
And he didn't have a mechanism, and he treated some patients with actually a Scottish surgeon, and they had very good results. And so then there were 2 randomized trials at the Mayo Clinic in the early 80s. And the problem with that is they gave it orally. They gave oral vitamin C, and they showed no benefit with oral vitamin C. So it kind of lay dormant for a number of years. Then a investigator at National Institutes of Health, Mark Levine, looked at the differences between oral and IV vitamin C. And the body has a great way. You can take as much oral vitamin C as you want. It'll probably make you sick to your stomach, but you'll only get a certain small level of vitamin C in your blood. Your body either stops absorbing it or excretes it through the kidneys, and it's very stable levels, unless you have scurvy or something like that, which is pretty rare. But when you give it IV, you bypass all those compensatory mechanisms, and you get really, really high levels in the blood. And at those high levels, it kills the cancer cells. And so this Mark Levine came from NIH to the University of Iowa. We heard him talk. He knew our lab was investigating pancreatic cancer. This is about 15, 20 years ago. And so we started doing some initial preclinical work. It worked great. It was like the best thing we've ever seen when we did it in cells, and then we did it in mice. And then we did a phase 1 trial, and it was well tolerated. Actually, the patients felt a little bit better when they got the toxic chemotherapy. And so we've just advanced it to a number of other cancers. And like I said, we just published a trial that showed that we increased overall survival. And not only did we increase overall survival, but the patients felt better. Mm-hmm. So they were able to get the standard chemotherapy for longer periods of time and for a larger amounts because they just felt better. They didn't have any adverse events with they didn't have as many adverse events with the standard chemotherapy. And so they were able to receive the chemotherapy for longer periods of time. So we're not sure if the vitamin C is killing the cancer cells. I think it is. But also the vitamin C is working and allowing the patient to get chemotherapy for longer and more periods of time. And that may also be benefiting the patient as far as killing the cancer cells.
Yeah, like that secondary effect.
Exactly. Yeah.
Yeah, I'm glad what you just said kind of made me think of a couple things. First of all, I'm glad that you noted that it's not oral, so that people aren't just like downing 700 oranges a day. So that it's preventative. And also just like the importance of that research piece of it. I mean, do you have any, I know you're at the University of Iowa. Do you have any concept of how many cancer related trials and research, specific experiments are happening at any one time?
Oh, you mean in the nation?
No, at the University of Iowa.
Oh, at the University of Iowa? Oh, gosh, I would say there's probably at least 30.
Okay.
A lot of those are industry trials. So some pharmaceutical company has a new drug that they want to try, and they reach out to a number of NCI designated cancer centers like ours and, enroll patients on those.
Yeah. And I'm just wondering, because I feel like sometimes people think of research in like this long view, which it is. I mean, you start something and years later you get a new drug, or decades later. But it also sounds like patients are benefiting in real time who are willing to go through these trials.
I would agree completely with that. In another trial we did, we combined in pancreatic cancer. Sometimes you have to use radiation, which Dr. Correa can elaborate on that. And so we combined the radiation with, they got IV vitamin C at the same time they were getting radiated. Mm-hmm. And it was a 6-week, they got it for 6 weeks along with the radiation. And we have 3 patients that that live now, are alive now 9 years after their treatment with no signs of any recurrence or anything. Yeah. And I think that's phenomenal.
Absolutely. I mean, yeah, maybe Dr. Correa could talk to about what you've seen. I don't know how long exactly you've been doing this, but what you've seen in terms of that evolution and what it's meant for patients in terms of like having just this incredible sort of toxic chemotherapy versus combining some of the treatments or using immunotherapy, or I don't know. Has there been any advancements in that in sort of the
Yeah. So I think every oncologist would say number one, immunotherapy has been the biggest revolution in the past, 10 years in oncology because you're using your body's own immune system to fight cancer versus just, chemotherapy is cytotoxic. It kills all cells, so cancer cells and the good cells. Immunotherapy is more targeted to just help your body fight the cancer cells. The only kind of downside is if you're on these drugs long term, like, I don't know, ballpark a year plus, your body might start attacking itself. So you might get some autoimmune disease, like, in the thyroid or in the liver and the lungs or something like that. But I think these drugs first rolled out for things like melanoma, renal cell carcinoma. And like Dr. Cullen said, they have been revolutionary, especially in melanoma. And now they're rolling out to more and more diseases. So just kind of 2 points for lung cancer. When I started doing this, you ask how long I've been doing it. It's been over 15 years since I've been a fully fledged doctor. When I started doing this, all we had for stage 3 lung cancer was chemoradiation. The 5-year survival was 15%, 1.5, abysmal. Okay.
yeah.
With immunotherapy after chemoradiation, if patients complete all of the immunotherapy, for a year after chemoradiation, the 5-year survival is 60%, 60.
Wow.
So it's really incredible. Now everyone completes, the full scale. So the average is probably about more like 40%. But if you're able to get through all of that, and the other thing is for colorectal cancer. So if you have a specific type of colorectal cancer, something called microsatellite unstable colorectal cancer, it is particularly sensitive to your body's own immune system kind of fighting off cancer. So in the new guidelines, one way to treat that cancer is to just give immunotherapy and watch the tumor. And if the tumor goes away, you're done. No surgery, no radiation, no chemotherapy. So that's something I think we couldn't have dreamed of, like even 5 years ago. That's some Star Trek like stuff with just, give some magic drug and something is gone. But for certain cancers, we're finding some sort of magic bullets that do pretty remarkable things, targeted therapies and immunotherapies.
Yeah, that's awesome. And Cathy, I mean, I feel like you're in a really interesting vantage point because you have seen several generations, go through treatment. Have you seen differences and changes just in your own personal experience and how they treat it, breast cancer specifically?
Well, I can say that I have. With my mom, that was my first run-in with cancer. So I didn't really know too much about it. And I felt like she didn't get the treatment that she needed. She lived for 4 years after her diagnosis, and then she died from breast cancer metastasis. With my girls, I think that they got pretty good information, and they knew exactly what they wanted to do. Like my Nisha, when she was 21 and was diagnosed, she was like, just take these breasts. I just want to have a double mastectomy and be done. And she did just that. She had a double mastectomy. She had chemo, and she went through radiation. When Shay was diagnosed, Shay said, take them, and I'm not doing radiation. She did do chemotherapy, though. So, yeah. And with me, my breast cancer, when I was diagnosed, and I actually knew what I wanted as well, but I could not have a double mastectomy because I have a transplanted kidney and I have systemic lupus. Okay. So I had to be very careful with what my doctors were going to treat me with. And I am a patient of Mayo Clinic, and they were like, no, you're not having this. And I was like, well, that's what I want. They were like, it's not in your best interest. And then they told me to think about it. We'll do whatever you want, Cathy, but you need to think about it. And I did. And of course, I followed what the team wanted.
Yeah. Yeah, that's really interesting, that surgical piece of it. I wonder if the doctors can talk about that. Has that changed at all, where you can just surgically remove something and then not do, a more like radiation or something that you may have done previously?
Yeah, that's for sure. I mean, less invasive approaches are becoming more and more common. I would say that that happens in colorectal cancer, where a lot of times the tumor was biopsied, and now sometimes they just need chemotherapy and radiotherapy.
Mhm.
Breast cancer, when I trained, it was a modified radical mastectomy where we removed the whole breast and all the lymph nodes. That's rarely done anymore, knowing the biology of the tumor. And there's some head and neck cancers where patients had chemo, radiotherapy, and very, I would say, disfiguring operation at times. And they're doing less and less than that because they see that the results are as good, if not better. And the side effects are less when you do the less invasive approaches. So I would say in the last 20 to 30 years, the trend is more less surgery and more other treatments.
Yeah, that's really interesting. I sort of personally, with my thyroid tumor, they said that there was cancerous cells within it, but because it hadn't spread, they didn't do anything but surgery. They just did a partial thyroidectomy, which I was like you, Cathy. I was like, take the whole thing, and they're like, maybe not. Let's not do that because you need a thyroid if we can save it.
And there's risks of doing something that extensive too.
Hmm.
Not only in thyroid disease but in other cancers too. There are risks and long-term side effects with some of those big operations.
Yeah. Go ahead, Cathy. We're going to add something.
No, I was just going to say that there are risks in just having surgery. Period. And I know when I had my rounds of chemo, and it did shrink my tumor, and then I had a lumpectomy, and it was like I said to my doctor, my surgeon, I said, now you're going to take a lump out of my chest. Am I going to have like a divot? Is my chest going to be disfigured? And no, I mean, I have this small line that you can barely see. I mean, it was like perfect. It was like pretty. I told my surgeon, I said, it's so pretty. So I think nowadays, the lumpectomies that I've seen, within the ladies in our group, I think they are less invasive. And I only have 5 lymph nodes removed. So yeah, I think technology has really come a long way.
Yeah, that's awesome. Well, and I wondered if you guys could talk at all about the difference, if there is a difference in screening for like a reoccurrence versus new cancers. So people who, like, how often, if you have had cancer, do you have to come back in for checks, or does it depend?
It depends on the cancer, but roughly in most cancers, this is a generalization. In most cancers, if they're going to recur, 80% of them will recur in the first 2 years. In most cancers, not all of them, but most cancers. So the follow-up on those type of cancers is probably every 3 to 4 months for the first 2 years. In general, that's a huge generalization, but that's usually what happens.
Yeah, okay. And so I wanted to ask kind of like what some of the sort of exciting new things you guys are working on or you're looking for. Like what have you heard in terms of the research space that you kind of think would be pretty incredible if it materializes?
Well, as Dr. Correa said, the immunotherapy has really advanced, and it's now instead of just lung cancer or some other cancers, they're using it so for many different cancers now. And so I think that will be an advancement. Other than that, I don't know of anything other than our studies with vitamin C, which are exciting. But from a national standpoint, I think, the immunotherapy is only going to get better, and it's going to get more detailed and more support, I would say.
Yeah, I would say, cancer, as opposed to, I think when we started, it was more of a one size fits all. And nowadays it's so much more individualized. So you have these NGS testing where you test, a tumor for hundreds of different mutations. And then you can, if there's a drug available for a mutation that a patient has, you can selectively give them that particular therapy to treat their particular cancer. So it's very different, much less cookie cutter than even like 5-10 years ago, because we can identify the biology of the cancer and figure out how to fight it more effectively. So that's only going to get kind of better and better. We're just kind of now parsing through all of the different, it has this mutation, it has that mutation. Do we have a drug for it? And especially for the breast cancer patients, it's just so complex. I mean, before we had a couple flavors of chemo, a couple, adjuvant endocrine therapies, and now there are basically dozens of options available depending exactly on your stage and your tumor biology. So it's, do enough to cure the cancer, but as little as possible risk to the patient. It's becoming much more individualized.
Yeah, that's great. Well, and obviously people are talking all the time about these cancer rates in Iowa. And I know we had another whole session kind of on looking at the reasons, the causes, and the research being done around that. Do you guys think, though, that like the increase in screening can help inform that question a little bit, or look to it like if more people are getting screened, can we kind of dial in on what maybe some of the reasons are, or not really?
I hate to say it's due to more screening, because you might miss the boat on why this is actually happening in Iowa.
Yeah.
So I'm a little hesitant to kind of put it up to that as far as, more screening.
No, yeah. Well, and what I meant was just like, do you think if more people are getting screened, we can gather more information about a possible cause? You know what I'm saying?
Yeah.
Inform the research.
Yeah, no, I think you're right. I mean, what I would like to see is it, Iowa is not a very diverse population, but we have different regions. We have large cities, and we have farming communities and rural communities. So is it more prevalent in a rural community, or is it more prevalent in a large urban center? Something like that, even, I think would shine some light on the problem.
Yeah, absolutely. Well, and I wanted to ask, and again, this may be a question for you again, Dr. Cullen, but there's been a lot of discussion around the NIH, the National Institutes of Health, and some of the funding, changes that are happening there. Do you think that are you concerned about any sort of impact there on cancer-related research?
Hugely concerned. Yes. It's so short-sighted. It's awful. And our trials were funded by NIH. And the budgets that we get from NIH are so small compared to what we have to do that usually we need some sort of philanthropy to add to it to even get by. It's going to be devastating, and you're not going to see the results in a year, but you're going to see it 5 and 10 years down the road. I just can't. The people at NIH that I know are phenomenal federal employees. They are there for the right thing. They don't get paid a lot of money. And it's devastating. I can't say, as you can tell, I'm very adamant about this, but it's just a huge mistake. It's a huge mistake.
Right. And I know some of the changes so far have been like restricting the budgets when it comes to like sort of ancillary costs. but it seems like those are actually relatively important to making a research project work, right?
It's huge. So at the University of Iowa, I think our indirect costs are 47%.
Mm-hmm.
Some places like Stanford or Yale, it's 70 or 80%. But what that indirect cost does is it keeps the lights on in the building. It keeps the building heated. It keeps the janitors to clean up the place. Do you know what I mean? It's just the basic stuff that you need to run a building. That's what that goes for. So it's essential. It's essential. It's
Right.
not like you're just throwing it away.
Sure. It's not like you can do it without it.
Yeah. You gotta, the Cedar Rapids Gazette has people cleaning up the offices and cleaning the bathrooms and all that stuff, right?
Yeah.
Yeah, you need people like that. And that's what those indirect costs go to. And the Trump administration is just making a huge mistake.
Yeah. Well, and I wonder about whether any projects have already been affected. Have you seen that? Or is it still kind of trickling down?
No, I've seen projects affected. For example, a very nice nursing project here done at the University of Iowa was going to look at mental health throughout the state, specifically in rural communities.
Mm-hmm.
And in their abstract, the kind of the short summary of what they're doing, they use the word diversity.
Mm-hmm.
And it was refused to get even looked at.
Wow.
Huge. It would have been huge for the university. It would have been huge for the state of Iowa. I've lived in this state. I was born in this state. I've lived in the state except for 2 years of my life. It would have been huge for the state of Iowa to do something like this with mental health issues, especially in rural America.
Right.
And that was not even going to go look at it because it had the word diversity in there.
Right. Yeah. I mean, obviously a big part of the cuts are happening tied to that DEI piece, that some of the funding, some of the grants had come with sort of requirements, and those are all being, the funding tied to that have been stripped away. So, yeah.
And they weren't even looking at diversity. They weren't
Right.
looking at, between African Americans and whites or whatever, Hispanics. It wasn't even involved in that. It was more the diverse areas of mental health in a rural state. You know what I mean?
Yeah.
It was just the word. Nothing to do with diversity.
Right. Yeah. I mean, have you seen projects be amended and changed, to try to get funding under the new rules, basically?
Well, a lot of people are just waiting to see what happens.
Mm-hmm.
And I know a couple of colleagues who are waiting to see what happens. But, if they're going to cut the budget, the funding rate on some of these grants is 6%. So for 100 grants that are submitted, only 6 get funded.
Mm-hmm.
And that's just a terrible percentage. People are just like the economy. People are kind of waiting and see.
Right. Well, yeah, I guess one question I had is that Governor Reynolds obviously has been made a push for more cancer research, as an aside. And so I know the new budget bill that just passed has $1 million set aside for cancer research at the University of Iowa specifically. But I just have a question, because honestly, it feels like it's hundreds of millions of dollars are going into cancer research right now from the NIH, and that you guys are losing many more than $1 million through some of these cuts. Am I right?
Yeah. $1 million is a drop in the bucket. I'm sorry. That's my last grant from the NIH was $10 million.
That's what I thought. I mean, go ahead.
Yeah.
I would just say, in regards to this, okay, cancer does not care if you are Republican, Democrat, or independent. Okay, this is something for all Americans, no matter what your race, religion. I don't care. Cancer doesn't care. Mm-hmm. It just wants to establish itself and grow in your body. It's a biological entity. It doesn't give a crap about all this political nonsense that's going on. And by turning off the faucet, you do realize that these immunotherapies that we're using today that are revolutionary, they were largely NIH trials that started in the 70s, 80s, and then you don't get them to fruition till when you use them in patients till 20, 30 years later some of the time. So by turning it off now, the funding for these sort of basic research, we're not going to see it right now. I mean, some people will see it right now, but really the big pain is going to be in 10 years when Europe is now the center for, cancer advancements and cancer innovation, and America is way behind. So I think we need to protest this in any way that we can. It's an issue for everyone. And just realize that it's not a political thing. It's a human thing. It shouldn't be, oh, this regime is going to take this away. And if some of my studies, they use the word gender, and they had to go through all these studies instead of running the cancer research. They're going through every single study we have, removing the word gender and changing it to sex. I mean, it's just a waste of time and resources. And I'm just worried where we're going to be in 10, 15 years with this going on now.
Yeah.
Well stated.
Yeah. Well, and what you just said made me wonder where we do sit in the world. Right now, is the United States kind of a leader in cancer research, or how is that? Like you mentioned Europe and China, where do they stand?
I would say that we're still a leader, but I think China is a very close second. If you look at any type of academic journals, there's a lot of Chinese a lot of studies coming from China.
Uh-huh.
They must have resources that we don't have, but it's pretty striking.
Sure. Yeah, and we did just get a question from the audience here, wondering if someone can discuss stem cell therapy just a little bit, and whether that's the same as immunotherapy, or is that a different thing?
It is a different thing. I'm not a expert on it, but stem cell therapy can be used in patients that this might be a bit of a stretch, but like if they have leukemia or something like that, stem cell therapy can be used, but it is different than immunotherapy.
Yeah. I mean, I feel like that was like the last controversy. I remember stem cells for a while were controversial, right? But has some of that sort of faded to where people are kind of honing in the use specifically?
Well, 30 years ago, one of the bone marrow transplant, which is a form of stem cell therapy, I guess, was used for breast cancer and was touted for breast cancer. And when they did the studies to look at that, they showed that the results were not very good. And a lot of people died from the bone marrow transplant. It was like a 10% mortality. So that fell out of favor very quickly. As far as stem cell therapy, I don't know that much about it, really.
Yeah. Yeah. Okay. Well, and I guess I'm just wondering, for people who are listening in, like, what do you think what sort of action can people take if they leave this conversation? Would you like to see sort of like more people doing self-screening, self-exams, coming in for screening, talking to lawmakers, legislatures? Like, what sort of action steps related to cancer, screening and treatment can they walk away with?
Well, I could say for breast cancer, I definitely think that if you find a lump, you need to go see your PCP. You should all be doing self breast exams monthly. Just mark it in your calendar and do it. And if you have any concerns, always see your breast care specialist.
Yeah, thanks.
Yes. I would say probably don't get cancer in the first place. So we're talking about screening, but the best thing is to never get it to start off with. So if you look at the risk factors, there's some things we can't change. We can't change that we're aging. We can't change our genetics. But what we can change is smoking. What we can change is, what we eat and what our body weights are, whether we exercise. So those are like the big things that people can do. I find people too often focus on, is there plastics in the chemical I'm eating and all that. All the rest of that stuff is kind of a little bit more like gravy. What you need to focus on is kind of what we know causes cancer, what we know you can change. Just a little bit of a maybe call out to radon. The radon levels in Iowa are through the roof. So everyone should have their house tested for radon, and if the levels are high, get a mitigation system, because that acts in combination with smoking to increase the risk of lung cancer. So still very low risk. You're probably not going to get lung cancer from that if you're a non-smoker, but if you're a smoker, it definitely contributes to some cases.
Yeah. Yeah. And are we understanding a little bit more about some of those risk factors? Because I mean, I do feel like smoking for a while has been known, like the sun damage. And then you mentioned like we aren't like 100% on like plastics or whatever, like that stuff is a little bit more iffy. But yeah, are we more for, like you've mentioned obesity a couple times. I know alcohol had been raised. I don't know. Some people have mentioned sugar. I don't know about that, but like, yeah, are some things kind of getting more firm connections to cancer?
Well, I think what Dr. Correa mentioned earlier was obesity with the correlation to cancer and smoking. And there's probably other things, where you live. But I think those are the main ones, probably.
The main, yeah, like lifestyle changes.
Lifestyle. Mm-hmm.
Yeah. Right.
I think what some people don't realize too is, especially for postmenopausal breast cancer, which is the most common type of breast cancer, you can reduce your risk of breast cancer, of getting it and of it coming back if you've had it by, 40 to 50% just by regular cardiovascular exercise. So, you have your oncologist prescribing you a pill and you don't want to take the pill and you're worried about that. We have something that's kind of the same level of effectiveness that I don't think it's touted enough. So ACS recommends 150 to 300 minutes of physical activity, or 75 to 100 minutes of vigorous physical activity every week. And that's going to reduce your risk of getting cancer, and for certain cancers, the risk of them returning.
Yeah. Well, and sorry, we're getting kind of close to the end here, but I did want to actually ask quickly, because there was a lot of discussion during COVID about people missing screening and treatments and exams. Did we see any sort of impact for a ramification of folks not getting tested during that period?
For sure. Just at the University of Iowa, the number of lung cancer patients dropped dramatically. The number of pancreatic cancer patients dropped dramatically. And a lot of it was they just weren't coming in to see their doctor. It did have an effect, definitely had an effect.
And did we see a sort of like rebound on because like, say I didn't go get my breast exam, you know what I'm saying? And then 2 years later, I have a sort of more advanced tumor I'm dealing with. Did we see anything like that?
I don't know any data that says that. I think we're back to what we were before, pre-COVID, I guess.
Okay.
As far as patients and screening and stuff.
Yeah. We have another question from the audience here. It says, it's asking if you all could speak to sort of prevention in terms of diet and exercise. We've mentioned alcohol. Yeah, you just mentioned cardiovascular stuff, Dr. Correa. Like, what is the exercise piece of it? How does that help?
Well, it reduces your kind of all-cause mortality, so risk of dying of anything, cardiac-wise, pulmonary-wise, but it also seems to do something in the body where at a cellular level, probably where your body is saying, hey, I'm alive, I'm being used, don't kill me, where it helps to prevent cancers from coming back. At least it's well established, I would say, for postmenopausal breast cancer. As far as diet, I can't speak to as much of that. There isn't as good data for diet as there is for exercise, in my opinion. And alcohol, so ACS says any alcohol, it's a carcinogen. So they prefer none at all. I mean, in reality, people do drink alcohol. So I would say it's best, if you're going to drink it, to have it in moderation.
Sure. So that wine stuff wasn't true. Just kidding.
It might be true for cardiac, but it's not for cancers.
Okay. What about chocolate? Is that still good for you? And then Cathy, maybe you can speak. I don't know what do they as a person who's been through it, did doctors tell you anything? Is your daughters are ringing the bells and leaving, like, are they told to do anything to sort of, other than just do self exams, like any lifestyle changes?
Yeah, like Dr. Candace said, I'm sorry, I can't pronounce your last name. Yeah, you have to exercise and you have to eat healthy. And my doctors told me when I left Mayo Clinic, do not drink wine. Just don't do it. Don't drink alcohol. And I'm one of those people that I was truly worried about recurrence because I was diagnosed with triple negative. So, and I also went 3 months to this oncologist in Waterloo and then 3 months in Mayo Clinic. So I was watched very carefully. However, I was still worried about it. And so I reached my 2-year, 3-month mark. I can kind of calm down a little bit. And now I'm shooting for that 5-year mark so I can be cancer free. But yeah, just the lifestyle changes and, exercising and, doing what you need to do to take care of your body.
Yeah, Dr. Cullen had said kind of 2 years is sometimes the state. So what did they tell you? They told you 5 years is when you're officially cancer free, or
no, 2 years because of
2
the
years.
triple negative. Yep, 2 years.
Yeah.
We gotta watch you up until 2 years, and then after I made it to the 2 year, which I just did, we kind of celebrated a little bit, but now let's try to get to that 5-year mark. So yes.
Yeah. And how are your daughters doing? Are they?
Oh, they're
doing clear?
They're doing well. They're thriving.
Yeah.
Yeah.
And I'm sorry, I didn't ask this earlier, but was theirs genetic? Is that what you determined? And you all had a test done?
Yeah, it was genetic on their father's side. And I didn't have it. However, I don't know if my mom, if hers was genetic. I didn't know that part of the history.
Yeah.
So, but when I got tested, I didn't have the gene.
Okay. Well, and just with my last question, maybe here, since we're almost done, Dr. Correa, maybe you could talk quickly about that genetic testing piece, because I know like people get the mammograms, pretty regularly based on age or whatever, but not everybody gets that genetic testing. Is that common, or is it only like something that you do if you have a family history, that kind of thing?
So it's becoming increasingly common. So, if you look at some of the guidelines, they recommend that any patient who's been diagnosed with cancer should be talked to about genetic counseling. So there's a difference between counseling and testing. So counseling is just where you meet with a counselor, you go over your family history, you go over, your risk factors, the type of cancer you have, and then they can make usually a recommendation for whether you should test or not. What are the implications of testing? So there's a whole medical profession set up around that. So most cancer patients, I think, or a lot of cancer patients are tested. Now, 90% of cancers are not heritable or not genetic as far as we know. But for, the 10% or so that are, there's some significant implications in screening for family members. And it's most easy if we test the index case. So sometimes people say, oh, my son, he'll get tested if he wants to in the future. It's going to be much harder to find the cancer-causing mutation than if we test you and see if, this is causing your cancer, and then we test him for the same mutation. It's just a lot easier to do. So
make those connections.
Yeah, I would say, but there are some legal implications that you have to go through carefully. So I think genetic counselors are the way to go to kind of, if you're thinking about that, to talk to them about it because they know the most. One thing that's exciting is besides just testing gene panels, like so a couple dozen genes to see if someone has a heritable mutation, we're getting close to where we have whole genome testing, where you not only test hundreds of genes, you test everyone's like 100% of their DNA. And so that's going to become cost effective probably within the next 10 years, hopefully. And then we'll have a whole new Pandora's box of cancer mutations and heritable mutations that we may be able to help us out with cancer patients.
Yeah, gosh, that is really interesting. Well, thank you all for being here. Thanks everyone for listening into this conversation. And we're so thankful to be able to have some experts to talk about this with. And so I guess I'm just going to close. This is our last day of the week. So there's not a session or anything tomorrow, but we have all this on the Iowa Ideas website, and all of the sessions are recorded. So you can go back and watch the YouTube videos and streams there. Just one more thank you to our ITC sponsor and Unity Point Health Cedar Rapids for supporting us. And obviously we have our big annual conference in October where we have lots of different tracks like education, environment, healthcare, all this stuff, all in one thing. So there's that. And then our next, we have one more in-depth week coming up before then, and that's on the energy and environment. So thanks again. Thanks everyone for being here. Thanks to our panelists. I appreciate it.